Thank you very much for the invitation to come today to Janet and Jill, and thank you to everyone coming on such a beautiful day. I'm sure there's lots of leaves to be swept up at home, so thank you very much for spending time here. My name is Steve Leslie. I'm one of the 5 consultant cardiologists at NHS Highland, and I was given the remit to talk about research and innovation in heart failure. I'm not sure why there was a question mark next to it, because there's no question mark over this. There's lots of research and innovation in heart failure. And what I'd like to do is give you a flavour of how things have perhaps changed over the year. And I've forgotten my clicker, so just let me get my clicker. Before I start, I'd like to ask you a question. Can you put your hands up if you were born in Scotland? Okay, that's fine. Can you put your hands up then if you were not born in Scotland? Great, okay, so everyone's awake and everyone can use at least one of their limbs. There's no excuse for not asking questions either after this talk or for the rest of the day, and thank you for that. I'd like to just talk through a little bit about the history of heart failure and how research and innovation has perhaps played a role over the years. Now, this was probably the sort of first person that described the heart as a pump. And described circulation, because before that we didn't really know an awful lot. And this is William Harvey in the 1600s. And moving on from that, about 100 years later, was the first demonstration of blood pressure. And this poor horse was sacrificed. This was actually a pharmacist. Paul's following me. He's a pharmacist, and in the bad old days, pharmacists got to sacrifice horses for research, and they put a tube in this horse's carotid artery and actually demonstrated blood pressure, because before that, nobody really knew that there was a pressure inside the system. And if you would all just like to make a fist for me, just make a fist and look at your hand, look at your fist. And that's the size of your heart, or that's the size of the average heart. It's not that big, but inside there's 4 chambers, there's 4 valves, there's complex wiring, electrical circuits, and the coronary arteries. And most people, their heart just beats away 1 time a second for your whole life, and you're not aware of it. And most people take that for granted. I know people in this room will not take it for granted, but most people take that for granted. The heart sits in the middle of the chest. It points towards the left, which is why we all listen over the left-hand side, but it sits pretty much in the center of your chest. And in one day, that fist-sized pump will pump your blood cells 12,000 miles. That's halfway around the world. That is absolutely amazing. Over your lifetime, it will pump enough blood to fill 3 of these supertankers, and they're both all 1 kilometer long, 48 million gallons of blood, and it just beats away in the background. And it's not just about the heart, it's about the tubes, the blood vessels that take the blood to the body and back. And when I was in medical school, the lining cells were thought just to be a sort of insulating layer to keep the blood in and everything else out. But actually we now realize that a lot of research has gone into these endothelial cells. And if you were to stretch from one single person, stretch all the cells flat, you would cover a whole football pitch, which again, I think is absolutely amazing. Does anyone know where this is? Pataudry, exactly. I was a kid in the 70s in the glory days, and unfortunately things have never been the same since. But of course it can go wrong. And here are some slides here, top right-hand corner. And what I would say about heart failure is that heart failure is the end product of almost all diseases of the heart. So there's not one thing that causes heart failure. There are lots of different diseases that when they affect people for long enough, they will result in heart failure. And you can see here a valve that's not working well and long enough, left long enough and untreated, that will result in heart failure. Rhythm problems, and the last speaker, David, talked very passionately about a cardiac arrest, and certainly heart rhythm problems will result in heart failure as well. But the most common cause of heart failure is coronary artery disease, and here's an artery here that's filled in with cholesterol deposition. Here's one here that's ruptured, and there's been a clot forming, and that would have caused a heart attack. And there are lots of great things about living in Scotland. But our legacy of coronary artery disease is not one of the things that we should be proud of. And you can see this map here on the right-hand side. I work in NHS Highland, and you see this huge big red splodge that's the Highlands. And look how much red this is the burden of coronary artery disease is compared with the south of England. If you look at the number of nurses and the number of cardiologists, it's inversely. So a lot of the cardiologists are down here in London, and I was speaking to one at the Scottish Cardiac Society last month, and he was saying, I've got no lists, I've run out of patients with coronary artery disease, and I was suggesting to him that perhaps he should move up to Scotland because they're all here. As if it's not bad enough to be Scottish for myself and male, it's particularly bad news for baldies. So if you've got bald head, you're more likely to get coronary artery disease. And there's a serious element to this as well, because men tend to get coronary artery disease about 10 years younger than women. And women are twice as likely to live to the age of 80. So we've really got a sort of male-female difference. And although women might think that guys have got a great time, right? You know, when it comes to coronary artery disease, we are, not doing quite as well. You'll see that some of us have tried to compensate for the lack of hair on top, and I've always wanted a beard, and it's only in the last 18 months my wife has allowed me to have one. She said, oh, they're dirty things, and doctors shouldn't have beards. They really are dirty. She's really sort of got this cleanliness thing. But I found this bit of evidence that beards are actually good for your health. And if I was to take a swab off my face and compare it to Dr. Murdoch there, I'm much less likely to have bugs on my face than Dr. Murdoch is. This is evidence, this is research. Anyway, coming on to heart failure. Heart failure is increasing, and despite all the things that we're doing, it's our own fault. Because despite our best efforts to smoke, drink, and eat ourselves to death in Scotland, we're actually living longer. People are living longer, and this is a success story. We're actually living longer. There's less coronary artery disease around, and people are surviving cardiac events. But the downside of that is that more people are surviving with heart failure. And of course, cardiovascular disease, and heart failure in particular, is a disease that affects older people. It can affect younger people, but mostly older people. And you see this graph on the right-hand side, and that by the time you're 85 or above, there's about a 9% chance that you might have heart failure. So if you're feeling isolated at times, you're not. There are lots of people around you who also have heart failure. Now, this is one of my favorite slides. It's a bit of lateral research, and it looks at the heart rate in mammals. And if you look at a mouse, it's got a very fast heart rate but doesn't live very long. If you look at a whale or an elephant, slow heart rate but lives quite a long time. And if you look across the mammals, they pretty much lie on a straight line. So all mammals have roughly the same number of heartbeats. If you plot humans on that graph, we're way out. Our hearts were only designed to live till we were about 30, 35. And that is one of the things that we're sort of fighting against and trying to help with the research and innovation and the treatments that we have. So thinking about innovation, things that seem innovative today and amazing today will tomorrow perhaps seem a bit barbaric, and I'm going to talk about some historical things. And research is important because we have to make sure that things that we innovate about are actually good for you. We've got to prove that things are worth investing in and suggesting for patients. So, of course, one of the major innovations that we've got are the tests. So if we look back to the early 20th century, we had stethoscopes. Here's an ECG machine, and they used to put the arms in salty water and measure the electrical activity that way. And here's an old X-ray machine. And of course, things have moved on amazingly in the last 150 years in terms of the tests that we have. Often quite simple things. This is a screening blood test for heart failure. If your BNP level is low, you don't have heart failure. If it's very high, you might have heart failure. And a simple blood test can screen out who may or may not have heart failure. Of course, echocardiography, I suspect all patients in the room here will have had an echocardiogram. Now, when I was a registrar, it was the size of a shopping trolley, and getting it up the hill to the neurosurgical unit was quite tricky sometimes. One of our registrars was too small to push it and had to get a porter to give her a hand. But look at this now. I can go up to my coronary care unit, put this in my pocket, and just walk around the hospital and scan hearts. It really is quite amazing, the miniaturization of the stuff that we've got. ECGs have changed. We no longer put people's arms in salty water baths. but you can have an ECG now in your home, and it can be sent by email to our coronary care unit. So there's been massive expansion in the innovation in the tests that we do. And X-rays have really come on amazing. This is John Miller, who's one of our amazing radiologists who can put a patient through the scanner and come out with these beautiful pictures looking at the coronary arteries. I can see inside my patient without having to be inside my patient. It's amazing. It's much safer and can identify coronary artery disease much earlier than we ever can before. So when it comes to treatment, there has been innovation as well. This is a man called Reginald Southey, and he was an innovator in his time, and he had patients who had swollen ankles. Now, many of you will have experienced swollen ankles. It's uncomfortable, it's horrible, it can really get quite big and be quite limiting. And what he designed were these things called Southey tubes, and I've actually got some with me if anybody wants to see them afterwards. And these were tiny little silver tubes that were inserted into the skin, and the holes here allowed the fluid to drip out. So he would stick these needles, these tubes, into his patients to relieve their swelling. And of course that now seems barbaric because we've got furosemide. So things change, but he was an innovator of his time, and research is important as we go forward. And of course in 1919, moving on a bit, there wasn't a thing called heart failure, it was called heart muscle fatigue. And there were some very important medications and advice, and in one of these booklets, or this book that I've got at home from 1919, so not so long ago, but within 100 years. And the first thing it says to treating heart muscle fatigue is to avoid flatulence. Doctors in the past were obsessed with bowels. I think patients were as well. So there's an awful lot about what you eat and making sure that you don't get too constipated or get too flatulent. But the other treatments that were used were strychnine, arsenic, and iron. We still use iron, but the first two have certainly fallen out of favour, and certainly in NHS Highland. Rest in bed was the other thing, that bed rest was a massive part, and we now know that's the wrong thing to do. Exercise is what we should be doing. They were very against game, so no duck, goose, salmon, pork, or high game for you guys, I'm afraid. So I don't know what's on the lunch menu, but you need to be a little bit careful what you choose. Sleep's important, and alcohol was a major part of the treatment. So hot whiskey, I don't know if that's on the lunch menu, but that still makes some people feel better. Of course, some of the treatments that were around are still around. So we have digitalis, and somebody know what this tree is?
Willow.
It's a willow, yes. So anyone know what drug comes from the willow? Aspirin, yes. So we still use a lot of digoxin and aspirin. And beyond that, we've got a lot of other medications. I know that Paul's following me, he's going to talk about drugs. And we really do have an amazing number of different medications that can make people feel better and live longer. I'm not going to talk about these in any detail at all, but only to say that for the drugs that you are prescribed and that we prescribe and that you take, they have gone through a massive regulation of innovation and research. They've been developed. It costs millions of pounds to develop any drugs. They're then trialed, and we have these big randomized trials where we take up to 10,000 people, and many of you may have taken part in trials, and if you have, I'd like to thank you very much, because without patients taking part in trials, we don't have the evidence for the medications that we have. Often the drugs will be compared against either other treatments or against placebos, so sugar-coated pills, and we will look at treatment A versus treatment B and see which is the best. And if we find that a treatment is good, then it will be licensed. That's with the European Medicines Agency, although after Brexit I'm not sure what will happen, but I'm sure that will change. And then once it's been licensed, more locally, we'll go through what's called the Scottish Medicines Consortium, which looks at drugs, looks at the cost, looks at the benefit, and decides whether it's a good thing for patients in Scotland to be offered these medications. There'll then be local guidelines and formularies, and eventually the national guidelines will be revised. They get revised every few years, and they will incorporate these new medications. So by the time it comes to a drug coming to you, it has been through an awful lot of regulation, research, and thought before we go with new treatments. And we tend to be quite cautious about new treatments because they have to go through this regulatory thing. And we often end up with these sort of graphs where we look at treatment A versus treatment B or different doses. This is an allopril at 20 versus 60 milligrams. Actually showed not an awful lot of difference, but these are the sort of graphs that we get presented with all of the time. Catherine Labinjo is going to speak to you in 2 talks' time about devices, but again, devices go through a very similar but subtly different regulatory process, but they all have trials just to show that they are of benefit. Of course, we also want to treat the causes of heart failure. I've not gone into that in a lot of detail, but again, there are lots of trials ongoing about the treatments that we offer: bypass surgery, stenting, valve treatments. These all are regulated and researched very thoroughly. And research is also important so that we don't give you things like strychnine and arsenic anymore, and that we find out which things don't work. And here's just a range of things that haven't worked. They've thought they were, people have thought they were a great thing to do, but research has taught us that they were not needed routinely in patients with heart failure. But of course, it's not just about drugs and pacemakers, it's about exercise and rehabilitation as well. And we know that heart failure and exercise is very important. Here's a training, weeks in training in cardiac rehab and a 6-minute walk test. And you can see that patients with heart failure with training, and you wouldn't automatically think that you should go through a training program, but a training program will improve your ability to walk and your fitness. And so we can say that exercise is good for you. It doesn't need to go to the gym. It doesn't mean putting on Lycra and getting sweaty in a gym. Maybe just simple things like walking rather than taking the bus, or getting off at one bus stop before your house, taking the stairs if you can. Simple things, walking out around the garden, depending on what you can do, but anything is better than nothing. I like this slide because only in America would you have a 24-hour fitness gym with an escalator to the front door and two fat Americans using it as well. So but it doesn't have to be gym-based. It can be just out there in the community and what you can get into your life easily and make it enjoyable. I think the biggest innovation, and this is research-based, the biggest innovation is the community-based heart failure nurses. They really have, I think, revolutionized. And we see in Janet and Jill, 2 nurses who are doing more for heart failure in the last couple of years than I think many of the doctors have. So I think I'd like everyone just to give our heart failure nurses a big round of applause. And these are the things that they do. I don't need to go through that. So where are we now? I'm wrapping up now. Where are we now? We have more treatments. People are living longer. Heart failure doctors, when they're looking for money for research grants, are very keen to say what a deadly condition heart failure is, and we really stress, and we often are competing against cancer charities for money, so we're always keen to stress how deadly heart failure is. But that's changing. The medications, the treatments that we got have changed heart failure in the last 10 years from a completely different outlook. But the downside is that more people have heart failure because people are living longer, and that does mean that we have to continue to expand our services, our heart failure nurses, doctors, and other facilities for people. And I want to leave you with this. This is some research just from my unit, and we looked at the cause of death of a patient in our heart failure clinic, and the majority of people with heart failure don't die of heart failure. They die of something else. And what's really important is that as heart failure doctors and nurses is that we work very closely with other doctors and other nurses around. So what's the future? It's team working. It's about making sure that locally and nationally we have the best possible systems to help our patients. It's about education, not just about patients. Patients are very well educated, but about other doctors, general practitioners, health boards and governments. And without getting too political, I think it's very important that we continue to keep heart failure on the agenda at your local health board level, but also with a government, so that people who are making decisions are making the right decisions for our patients. Technology, Janet talked on this, using existing technology as best we can, but continue to innovate and find new things that we can. But I think most importantly is humanity. Gone are the days where Reginald Southey and his tubes could stick into people. I think that we have to work in partnership with people, and I know that sounds a little bit corny, but I think it is important. The days of the doctors up here and the patients and nurses down here are gone. We should really be working as one big team and trying to pull together for everyone's benefit. And I think that where humanity comes into it is patient-related outcomes and realistic medicine. Heart failure affects a range of people, and not everybody will need the same medication. And I think what's really important is, what do you want? When you're speaking to your doctors, patients sometimes turn around to me when I have this discussion, they turn around and say, well, you're the doctor. Yes, I'm the doctor, but you have to take the medications. You have to take the treatments, and it's very, very important that that is in partnership. The last speaker, David, talked about opening his heart, and I think that chimes very well with my last slide, which is there's something very emotional about your heart, about being something wrong with your heart. When there's something wrong with your heart, it flavors your whole life. It really undermines your confidence, and I think that we've known that for a long time. The use of the word heart is throughout our language. So I'm going to stop now. If there's time for any questions, that'd be fantastic. My email address is at the bottom, and I'm really more than happy to take email questions anytime or to answer questions just now. So thank you very much for listening. Thanks.